Mississippi Medical Center. So, as always, we're going to introduce ourselves and we're just going to ask a few questions, and hopefully, this will be informative for you as I know it will be for me. So, we'll just get started and we'll just go around and have everybody introduce themselves.
Yeah. Well, thank you for having us. I'm Keith Mansel. I'm the physician, the doctor on the team.
My name is Ann Andrews. I'm a nurse on this team.
My name is Sheena Moore-Carter, nurse practitioner on the team.
Okay, so as I ask questions, of course, everybody can just jump in and fill in as they need to. So, the very first question, of course, since we're talking about hospice and palliative, is can you all explain the difference exactly what is hospice and what is palliative care? Because I know sometimes that can be confusing to people.
Yeah. Yeah, that's a great question. We get asked a lot.
Mhm.
I would say the the bigger circle is palliative care. Palliative care is taking care of folks who are seriously ill, treating symptoms, pain, shortness of breath, things like that, helping them with emotional and psychological support. One of the big things we do is really help them um, with decisions, being sure that they have good information, asking good questions, and that they're really focusing on care that is important to them based on kind of where they are in their illness. Someone had said that we act as a sort of a seasoned medical travel guide. I like that terminology. Whereas hospice is more uh, treating folks who we think generally are going to have a limited lifespan, often less than 6 months. Being sure they're well cared for and that whatever time I always say in hospice, we want you to live as long as well as you can, given the situation. It's sort of a change in focus and a change in philosophy about, people want to be at home or wherever they live, not come back to the hospital and live their time as best they can. So, if that's helpful a little bit, yeah.
It's helpful. So, when you hear the word hospice, sometimes it brings fear into people. So, what do you wish that the public would generally understand about hospice?
Well, personally, I would say that the fear oftentimes comes from the thought of death. And so the hospice companies help with ushering people into a place that they have less symptom burden, their support for family members, and also spiritually, sometimes their struggle, I think, at end of life, just the thought of dying. And so hospice is experienced in helping people through those hard times, good times, and just making sure that they have all that they need as they're transitioning.
Thank you.
I think the key thing is that in hospice, we want you to live as long and as well as you can. And it's a lot of good help. And it really helps someone be at home and be with their family. It's more folks taking care if it's hospice in a facility. It's a lot of good help, and it is also covered by Medicare.
That's right.
And so I think when it's time for hospice, it can be a real blessing for folks.
I know what drew me into actually hospice and palliative care was after internal medicine and then doing geriatrics and then actually having my great grandmother who was actually on hospice and watching her die from colon cancer. It's just something I think that's been near and dear to my heart. What drew you all into hospice and palliative?
Yeah. Well, I got there. My journey was a little bit personal. I was a lung and intensive care doctor most of my career, and then I had a long bout with back trouble, spine trouble, and spinal fusions, and really a significant amount of pain at times, pinched nerves. And so that's an eye-opening experience, particularly for a doctor to now be on the other side of the bedside. And I got through those things to a great degree, and I thought, well, I'm going to go back and get back to work. And I said, well, I'd been a patient and had pain, and that gave me different insights. And the other thing, I'd spent so much of my career as an intensive care doctor out in the waiting room talking to
Mhm,
families, and I
mhm.
thought, well, that maybe I have some experience there. Then it kind of drew me in that direction.
That's like a natural, almost like a natural progression
Seemed to
there.
be, yeah, for
Mhm,
me. Yeah.
Nursing is a second career for me, and I
mhm,
actually got interested in nursing because I had spent some time with folks at the end of life who were in
mhm,
hospice, and I thought, you know, I it's a really an honor to be with to walk with people
mhm,
during that
mhm,
time of their life, and I hear from you and your grandparents. But and I really thought, well, that might be something I'd like to do
mhm,
for the rest of the time that I'm
Mhm.
on this
mhm,
earth working.
mhm,
So I went to nursing school, and then I did some regular bedside nursing, and then I did do hospice. I was a hospice nurse taking
Oh,
care of
okay.
folks in their homes for about 4 or 5 years, and then that led me to here.
Could you?
My journey is a little different
Mhm,
also. So I started working here at UMC in wound care,
mhm.
working with wound, ostomy, and continence patients. And when I first started, I read many of Dr. Mansel's
Uh,
notes.
mhm,
And his notes, I had never seen anything like it.
mhm,
You get a connection with how he portrayed the patients.
mhm,
The patients were human beings,
mhm,
and
mhm,
he went beyond just their physical diagnoses
mhm,
and what we saw going on with those patients here in the hospital. He drew out the person, and I could see just their, I guess, pathway up until that
mhm,
point,
mhm,
and it was beyond the hospital walls.
mhm,
They were real people with real stories, and so I think that helps create a connection with patients
mhm,
in
mhm.
palliative care, walking with them through hard journeys. I think
Yes.
that
Mhm,
helped me have a connection with
mhm,
palliative care, seeing
mhm,
that through
mhm.
Dr. Mansell.
So he was just able to create a picture that you could
Mhm.
read and not even seeing someone face to face, and it's
Right.
just good.
Mhm.
So when is there any point of illness that someone should start considering palliative care?
Well, we think we ought to. I wish we saw folks more upstream in their
Mhm,
illness.
mhm,
Too often, palliative care still has a connotation of end of life, and of course, do want to be sure people at
mhm,
end of life are well taken care of. But a lot of the symptom burden and also the beginning of decisions can happen. We see
mhm,
folks maybe who have chronic heart failure, kidney
mhm,
disease, and all of a sudden sort of they end up in the ditch, clinically, and decisions got made. And we see them think, boy, if we had seen them even a year ago and sort of
mhm,
walk through this. So I think anytime somebody has a serious illness or, what's also been talked about as the surprise question, if
uh-huh,
if
mhm,
if you wouldn't be surprised if somebody died in the next year, it's probably not a bad idea to begin
mhm,
having
mhm,
conversations. And
mhm,
one thing we try to do is help best we can. We do a lot of talks and go talk to the teams after we see the patient. We try to educate our colleagues and residents about that they can have most of these
mhm,
conversations themselves.
mhm,
And sometimes I think we don't make a big difference. And then, like today, we talked to one of the fellows who had rotated with us earlier, and I thought,
mhm,
you know what? We made a difference
mhm,
there.
mhm,
That patient is benefiting from his having spent some time with us.
mhm, mhm, and that's what it's all about.
Yeah,
Mhm,
passing it on.
mhm, and
Yeah.
another thing we hear this word goals of care, and a lot of times people I know when I talk to them, what are you talking about goals of care? And so in layman's language, how would you all say what are goals of care?
Mhm.
It's really figuring out what's important to the patient.
Mhm,
After they
mhm,
have information, it's up to us as travel
mhm,
guides to
mhm,
figure out what direction in their care path is most important with the
mhm,
options that they are given,
mhm.
given their clinical circumstances.
I like that,
I
the
like
care path.
I like
Mhm,
saying, and we say this a
mhm,
lot. Here's what's the matter with you,
mhm,
and now we want to know what matters to you, and it kind of simplifies.
I think sometimes we can help people with I'll often say, I'm not as smart as I'd like to be, but here's some questions you need to ask.
Right.
Here's the information you need so we can kind of all together figure out, knowing what's important to you, come up all together in a shared way what's best for you. Because a lot of times, patients, how would you know? They don't know the
That's
questions
right.
to ask. And I certainly don't have all the answers, but generally we can help them with this. Is, if you're talking about chemotherapy, this is what you need to ask them.
That's
what
right.
are you hoping for? Those kind of things. So I think sometimes that's where we can be helpful.
And it feels really good walking into a patient's room and having no agenda.
Yeah.
The only thing we want to do is get to know someone and find out what's important to them, and then advocate for them and help them in that space.
So can palliative care actually be given to someone who still wants to have curative treatment, or they're still wanting to get this cancer cured, or any other terminal illness that they might have been given a diagnosis of?
Yes, they can still receive palliative care. It's about helping with their symptom management and helping them, if the path changes along the way, how they can be treated and continue to be cared for. We want our patients to always know they will always be cared for, no matter the method of care they're receiving. They will always receive care.
And I'm going to shift a little bit too about term people hear. Sometimes they'll come in the hospital. Well, do you have an advance directive? And people give you that blank look, like, what are you talking about? Can you all shed some light on what are advance directives, and maybe how that even differs from a DNR?
Yeah, sure. And two parts to the advance directive. One is the living will, which is in advance trying to direct what kind of care you might want. The other is if you couldn't make decisions, if you didn't have capacity, is a term we would use, who would make decisions for you? I think there's probably general consensus in palliative care, and I certainly share this consensus, that the most important thing is having a good decision maker or decision makers, and that they know who you are, what's important to do, what your values are. Because it's hard sometimes to say, well, 10 years down the road, if this happens, that happens, do that. That whole living will thing. Not that it's not important, but we like, who's your decision maker, and then what are your values, so that decision maker or makers, if the time comes, then can help make those decisions for you.
Because I found that sometimes I might ask a person, who is your decision maker? And it might be an elderly mother who's in a stroke or nursing home, and they haven't even updated or even thought about this or things like that. So there's a reason why I bring up this topic, that it's so important for people to start thinking about, like you said, who's going to make that decision for you when you can't make those decisions for yourself.
Yeah.
And why do you think, and this is just personal opinion now too, why do you think just death and discussing death sometimes seems so taboo? Because I get all the time, oh my God, how can you work in hospice? How can you do that? That we can start making it seem so less severe. Any suggestions for clinicians or people out there?
Oh, we have experienced amazing things at this hospital, people that have walked through that, and we've walked with families and patients, and it's really been a blessing to so many, and it can be really beautiful and holy, and it's a great time for families to honor their loved one. And we've also walked with people who've been very alone and afraid. And I think it's just part of the human experience.
So would you say, is there a good thing? Is there actually a good death? Would y'all say that can actually be a thing, that there is actually a good death?
I feel like I've seen that here.
sometimes we speak about how it's a gift for our patient who's sick to tell their family what's important to them.
Mhm.
And it helps those family members make decisions that otherwise would feel impossible. And to me, I would say that is a good death. Being able to be honored in that way by their family and some of that burden be taken from them. When Dr. Mansel was saying having that
Right.
surrogate there, and you've spoken to the surrogate about what your values are and what you would want or what you would never want, and then your family's not struggling at that time, they can be your family. They can surround you and love on you and just allow you to have that peace. And I think that's a gift to your family and
That's
to
right.
yourself.
And what? Oh, I'm sorry. Go ahead.
Yeah, I was just going to say, we see a fair number of folks in the intensive care unit, and those can be challenging times for everyone because sometimes, what's going to happen ultimately is uncertain. And but I do think sometimes we do focus, and we should focus on the patient. But sometimes I worry about this. What happens to the family afterwards? What is the trauma? This whole concept of post-intensive care syndrome family, that when these things drag on and up and down and months sometimes when when we know the outcome's not going to be good, and I just it's just so distressing sometimes when the family is under so much distress and they're having such a hard time with decisions and they don't really maybe know, and I wonder, I mean, that's a lot for the, and I think it's, for some folks, it may be a lifetime of trauma after a long ICU stay, a lifetime of trauma. Unfortunately, we're seeing someone now that I'm sure there'll be lifetime trauma. Not anybody's fault.
Right,
it's just
right.
just a really hard situation.
And I'm glad you mentioned that, because my next question was, why is it so surprising, and what do you think is most difficult for people to handle during the end of life process with their loved one?
Not wanting to let go.
Yeah.
And it's different when someone dies young.
Yes,
and
yes.
unexpectedly and traumatically, than someone who's lived a long, full life.
That's right.
And we have seen it all.
My experience over the years is one of the most challenging things at end of life is unreconciled conflict. Either between the patient and family members, or between amongst family members. And and we do the best we can to try to really lean in and listen and learn, but we can only see the tip of the iceberg sometimes generations of family developmental trauma, whatever is going on. And so when there's that conflict, and it's just human nature, it's gonna come up. When some of those things happen, I think those can be really hard for folks at the end of life. And then I think about that family recently from down in Southwest Mississippi. I mean, sometimes, I will tell people, I told this family because I believe it. I said, sometimes I just about give up on the world. Like, I turn on the news and there's just so much and everything. And then you meet a family like this and you go, where did that come from? I mean, just the grace and the graciousness and the love. And you go, you folks got it right. It's not perfect.
That's right.
Doesn't mean they don't.
Perfect.
They can be a little this and that. Of course it is. It's human nature. But I speak for all of us, I think. But it's those kind of things. If you can have one of those a month, it'll keep you going. It'll keep you going. You say, you know what? We're doing good work. Because sometimes, you just, there's some Fridays you walk out here and you go, what do we do this week? Nothing went well. And people, and then, but if you get one of those now and then, it's like, okay, I'm recharged. You go.
And I know some of the challenges I deal with is you have those conversations with people and you discuss and you think they know the hospice philosophy, and then when I actually get them in the hospice unit, it's like families are doing a 180 on me, and then all
Mhm.
of a sudden is I don't want this, I think I want this, and maybe you
Mhm.
should have put a feeding tube and things
Mhm.
like that.
Yeah.
And so it it's very hard sometimes getting people think that they know end of life
Mhm.
care or what's coming, and it sometimes seems like when it actually hits them when
Yeah.
it's coming, I don't know if it's a panic or if it's not
Yes.
really understanding. And I'm glad we're having this conversation. So hopefully people who are watching can start making those decisions,
Yeah.
preparing, and which leads me to, so if someone's watching right now and they're really struggling and they're overwhelmed, or they're a caregiver, or they're taking care of somebody and they know that that time is approaching, is there any advice that you all can give them that might help them during this process?
As a caregiver,
Mhm.
well, we always tell folks it's never a one person job.
Mhm. Mhm.
I think caregivers have so much burden. I mean, no matter what illness or disease that they're dealing with, but we really try to encourage folks to gather
Mhm.
friends and family. Got to take care of yourself too. Um,
Mhm.
uh, it's at least a 2 or 3 person
Mhm.
job.
Mhm.
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 There are a lot of folks though that kind of want to do it on their
Yes,
own.
yes. Mhm.
But
Mhm.
I do
Yeah.
think it's
Mhm.
important to gather folks to help.
Mhm.
And it's really an honor to walk with people. And
Mhm.
so taking a different perspective of walking with their family members, being
Mhm.
with them, and just their presence
Mhm.
being there. And whether it's the caregiver or family and friends coming in and visiting, surrounding them and ushering
Mhm.
them, that
Mhm.
is really, there's no price you can put on that.
Right, right.
And so looking at it from that perspective, I think could be helpful for caregivers and
Mhm.
people who are supporting the caregivers. And as Anne
Mhm.
said, they need a break also.
Yes.
So
Mhm.
just being mindful that it is a 24/7
Mhm.
job around
Mhm.
the clock as you're,
Mhm.
taking
Mhm.
care of them in the days and the patient's
Mhm.
weaker and having more symptoms, and that can be more distressing on people
Right.
giving the physical care. So having a good network of people to help is it's very important.
And for those people, again, who might have misconceptions, exactly what are the services that hospice can provide? Because you talked about a break, which is respite, what a lot of
Mhm.
people don't know about.
That's
So
right.
exactly what services are out there that hospice can actually give someone?
Mhm.
Well, we always try to describe what hospice is
Mhm.
and what it isn't.
Mhm.
What it is a team of
You're
folks
right.
that come
Mhm.
into your home and
Mhm.
or at a facility. I'll just
Mhm.
kind of speak
Yeah.
from
Mhm.
a
Mhm.
home based care. A nurse, an aide, social worker,
Mhm.
chaplain. There's a medical director that helps guide
Mhm.
them to assess and make sure those symptoms are being treated. People need to be comfortable,
Mhm.
peaceful, clean, safe, all those things available 24/7.
Mhm.
But they just confer like an hour at a time.
Right.
All the care is done by family and friends.
Mhm. Mhm.
So they're in and out, but they do a lot of educating. Make sure you have what you need. Make sure you know what
Mhm.
to look for. Maybe know what to do when something's not quite right. Someone to call, someone to come in the middle of
Mhm.
the night.
Mhm. Mhm.
Um, what am I
That's one
missing?
of the great things. We often use the term safety net because if it really, what's important to you is being at home, not coming to the
Uh-huh.
hospital. If you don't have that hospice nurse with a medical director to call at 2 in the morning, as this is calling 911. You go to
Yes.
the emergency
Mhm.
room, and
Mhm.
the clock starts all
Mhm.
over again,
Mhm.
and you know how that goes, and
Mhm.
people don't know you and down there for hours, and so it can be such a great safety net for people if things line up with what's important to them.
Mhm.
And
Mhm.
you mentioned respite, and respite is, I think, a 5 night period
Yes.
where
Mhm.
um, a caregiver can have a break.
Mhm.
You know, need to go on a trip, need to
Mhm.
do something, just need a break, and
Mhm.
their loved one can go to a facility somewhere and be
Right.
cared
Mhm.
for.
Yeah.
Mhm.
And that is a great benefit, and
Mm.
we don't really talk about
We
it that
don't.
much. We
Mhm.
should, because it is
Mhm.
it's a good benefit. People need
Mhm.
it.
So again, I thank you all for taking your time out of at the end of the day. As we close, is there anything that you all would like to share that I might not have asked or talked about?
I would just thank all the families who care for
Mhm.
people and all they do for their loved ones that,
Mhm.
who are seriously ill at end of life. As Ian said, the caregiver burden can be great, and
Mhm.
sometimes we
Mhm.
don't appreciate all that people do for others. And
Mhm.
I have great
Mhm.
respect for those folks.
I agree.
I agree. Mhm. I
Thank
think
you.
he summed it
Yeah,
up.
thanks
Thank
all you
you.
do.
Well,
Thank
thank
you.
you. Thank you. So everybody, I hope you enjoyed this show of the well, and you all have a good evening. And remember, I wish you well.
Mhm.
All right.